Hello, everybody. Welcome to the Consortium side event. In this session, we're focusing on promoting evidence-based investments in sanitation and hygiene for health and equity. I would like to welcome you all to this session, and also all those joining online. We have an interesting program for you today. And I would like to invite Professor Christine Moe, the Director for the Center for Global Support at Emory University, to start with the welcome and introduction. Thank you.
You've got to introduce yourself. So thank you. I want to introduce my colleague, Habib Yakubu, from Emory, who is so modest that he forgot to introduce himself. Can you hear me all right? Yeah, okay. So my name is Christine Moe. I am the director of the Center for Global Safe Wash at Emory University. And I am so pleased to have all of you here. A warm welcome from all of us. I am representing our consortium of 7 countries. And we are very happy to have you here. So last year we had a side event where we introduced the Promise Consortium. And this year we are so excited to tell you about the work we've been doing. So the Promise Consortium focuses on 3 main tools: the SaniPath Exposure Assessment Tool, the Compass Sanitation Assessment Tool, and the WashFit Wash in Healthcare Facilities tool. We are a consortium of 7 countries, and we have different partners in different stages of their work and using different tools, sometimes in different ways. Our main principles of operation is that we focus on team science and peer-to-peer learning. We also do a lot of stakeholder engagement on understanding the information needs of our stakeholders so that we can use tools to collect the data that the stakeholders need for making decisions. And then our third principle is moving from evidence to action, taking the information, the data that we've collected, making it accessible to the decision makers who need that information to make decisions about policies, about investment, about practice. As a health person, I want to mention that one common health concern in all of the 7 countries is increasing frequency of cholera outbreaks. And so some of that work that you will hear about is being done in areas where there are cholera hotspots. So with that, I'm going to move to a short video that tells you about our Promise Consortium.
The Promise Consortium is a multidisciplinary group of researchers and practitioners from 10 institutions in Africa, 2 institutions in Asia, and 2 universities in the United States of America. That is University of North Carolina and Emory University. Promise stands for Promoting Evidence-Based Investments in Sanitation and Hygiene for Health and Equity. This consortium was started in 2022 with the initial meeting in Seattle, and this meeting was convened by the Gates Foundation. Following that meeting, we wrote a grant proposal that was funded by the Gates Foundation, and currently we are implementing 3 critical activities. First and foremost, we are using innovative tools such as the SaniPath tool, the Compass tool, and the WashFit tool to study sanitation and food hygiene in communities, as well as infection prevention and control in healthcare facilities. Secondly, with the support of Emory University and University of North Carolina as technical advisors, we are building capacity in the institutional, in the partnering institutions and member countries for the utilization of these sanitation decision-making tools. And thirdly, we are promoting and advocating for the institutionalization of these decision-making tools into existing policies and guidelines.
I was one of the founders of this Promise Consortium. I've been in the field of water, sanitation, and hygiene for about 40 years, and I have seen that this is a very challenging problem globally. So the Promise Consortium is really taking a public health perspective on water, sanitation, and hygiene, and looking to see how can we support decision makers to make better, well-informed decisions, informed by evidence, informed by data, so that they can target the areas that need investment the most, and that would be most effective in protecting public health and protecting the environment.
We started initially with two tools. We had one which is called SANPATH, which is led by University of Emory, Emory University. The other one is Community Hazard Pathogen Flow Tool, which is led by University of North Carolina. So those were the first tools. And if you look at the SANPATH tool, it's a really good tool that it takes you all the way to look at exposure pathways and talk about what are likely to be, public health impacts that happen during those exposure pathways. Whereas when you come and look at the Community Hazard Flow Tool, it looks at the sanitation infrastructure and it looks at what are likely to be the unsafe releases of human excreta from these infrastructures, and what are the pathogen or hazard related issues with these kind of unsafe returns. So the two tools are really great tools because they help decision makers in how to prioritize sanitation decision making.
We have identified 3 communities, for instance, in Kampala. Some which are predominantly sewered, some have a mixture of sewer network and on-site sanitation facilities, and another is predominantly with on-site sanitation facilities. In these communities, we identify the hazards where there is a possibility for pathogen release into the environment. And as I said, it could be as a result of an improperly built containment, for instance, a pit or septic tank. It could be a sewer that is leaking, which means that there were probably not sufficient operation and maintenance in place to make sure that it is tight and not leaking and releasing sewage in the environment. So we go on to these communities and we undertake transit walks, walking in these communities, try to identify whether potential hazards can be found.
So if we share together our work between like Asian country and African country, that will also help this Promise Consortium to bring more like strengthen, and we can actually work further to actually improve the situation.
As a university, we do not have everything that is required. So through this consortium, we'll be able to get exposed to other things beyond what we already know.
I strongly believe that the tools developed and the evidence they'll generate will be very important and pertinent if we make them possible to be understood by the layman. I think they can actually really help in transforming our healthcare facilities.
Well, what we found out is that women are very active in these communities. They're organized around different structures, and they can really get involved in almost everything that we do.
I am happy to be part of the Promise Consortium. One thing that is unique about the consortium is the wealth of expertise and the different institutions, both in Africa, Asia, and in the US.
All right, so That's a good introduction to our consortium, even though it had some of us with our mouths hanging open for a few seconds. You could still get the general idea. So we are very grateful for the support that we have from two foundations, the Reckitt Global Hygiene Institute and the Gates Foundation. So I'm very pleased to have Ms. Sarah Roberts from the Reckitt Global Hygiene Institute and Dr. Najib Lokoya. Where are you, Najib? There you are. Thank you. Who are going to give a couple remarks about their reasons for investing in a consortium and the value they see from this investment. So thank you very much.
Afternoon, everybody. As Christine said, my name is Sarah Roberts. My name is Sarah Roberts. I'm Executive Director of the Reckitt Global Hygiene Institute, and it's a real pleasure to be here today. I think not least because this discussion goes right to the heart of what makes impactful science. So collaboration, stakeholder engagement, and translation to policy and practice. And the Promise team's work shows how connecting disciplines and perspectives can turn research into genuine real-world change. So the focus on understanding how pathogens move through our environment is of course crucial. And considering the esteemed audience I'm standing in front of, I intend to make no insight into that particular aspect, but maybe talk a little bit about how important it is that our knowledge is shared, acted upon, and embedded in our decision making. That's where partnerships between researchers, governments, and communities become so very powerful. So today's conversation, I feel, captures that perfectly. Science that's collaborative, contextually grounded, and policy relevant. It's about ensuring evidence doesn't stop at discovery, but drives action that improves health and resilience where it's needed most. So for RGHI, this consortium really reflects what we value the most: equitable, evidence-based collaboration that strengthens capacity and drives policy-relevant science. So on behalf of RGHI, I just want to thank everybody, the Promise Consortium, for their incredibly hard work and for evidence what truly equitable applied hygiene science can achieve. And just to say that I'm really, really looking forward to today's session. Thank you.
Thank you. Good afternoon, colleagues, partners. Good afternoon. Good afternoon. Good afternoon. No, I'm so excited to be here. And first of all, thank you so much to the consortium for the impactful work you're doing. On behalf of the Water, Sanitation and Hygiene team of the Gates Foundation, we are so proud of this work. I think I'll not mention some of the value-added outcomes that you've already outlined, but I will just raise a couple of things. One, where we sit at the foundation, we also work with multilateral banks and other funders, and we continue to see programs that are investing in sanitation systems and facilities that do not address public health fundamental issues. That's the pathogens, elimination of pathogens, protecting environmental quality, and making sure that we do not recycle grossly used disease. You go to a health facility to be treated and come out with new infections. I come from Uganda, and I know many mothers and parents have now been used to a new disease. My children are infected. The doctor said it's an infection. It's an infection. That's not acceptable. So at the Gates Foundation, we are really super proud of this work, especially in driving evidence that is going to help governments and investors and private sector and innovators to make sure that we address the issue of pathogen removal, especially from sanitation systems. As you know, the Gates Foundation work focuses mainly on health, global health, especially addressing elimination of infectious diseases across the globe, but also we are increasingly doubling down on maternal and child health. And these are linked, tightly linked to the work that we are doing here. So the evidence generated from this work, we see it as super impactful in supporting policymakers, in supporting ministries, in supporting utilities, municipalities, to ensure that they prioritize some of this work into their planning, into their investment, and targeted actions to make sure that sanitation systems actually deliver on the expected outcomes. Lastly, I also want to applaud the team and amplify that under scarce resources, I think those who are in the panel, you heard that. Under environments of scarce resources, we need to see more of these collaborations where we synergize not just in terms of expertise, but also resources and capacities, and jointly mobilize. I'm so happy and proud of the South-to-South collaboration and the North, you know, reinforcing the UNC and Emory, reinforcing the South partners in driving this work. I think we need to see more of this and make sure that we efficiently maximize the impact of every dollar or every euro or every shilling, wherever you come from, to achieve the impact we desire to have in the world. I thank you. Thank you so much.
Okay, thank you so much, Sarah and Najib. We are so grateful for your support that makes this work possible. So our side event today, we're going to start with 3 presentations that represent the work in more than 3 countries, in several countries. And then after that, we're going to have a panel discussion and time for audience questions and feedback. So first, we'll have a presentation from Dr. Richard Mugambe about the work he's been leading in Uganda. I'm going to use this one. Sorry, and this last slide. Okay, I think that's you.
Thank you so much, Kristen. Good afternoon, everyone, and welcome to this side event. I'm Richard Mugambe, and on behalf of the Promise Consortium, I'm presenting part of the findings from the work that we've been doing in Uganda and in Senegal. And this is looking at water, sanitation, and hygiene, water, sanitation and hygiene status, and environmental hygiene healthcare facilities in Uganda and Senegal. The prevalence of healthcare-associated infections in low and middle-income countries, and especially in sub-Saharan Africa, remains high, mainly because of a number of factors. But some of the critical issues here are to do with inadequate infrastructure and issues related to low compliance to guidelines, among others. And if we are to tackle the challenges related to healthcare-associated infections, we need to have in place relevant policies, as well as ensuring that we have infrastructure and behavioral interventions that will address these challenges. Unfortunately, across many countries in sub-Saharan Africa and Southeast Asia especially, the status of wash, environmental cleaning, energy, among other domains of the wash fit aspects have not been well documented, and interventions to address these issues are still needed. And therefore, the research that we are doing sought to establish the status of wash and environmental cleaning and hygiene and associated factors in healthcare facilities in Senegal and Uganda, and also to integrate decision-making tools into policies and guidelines. Our current research with funding from RGHI and the Gates Foundation is quite broad. We are currently focusing on phased interventional research to understand the impact of selected interventions on hand hygiene and environmental cleaning and hygiene, and consequently health. But for the purpose of this presentation, the results that we are going to share are going to mainly focus on the formative phase, which had 3 specific objectives. First, to establish the status of water, sanitation, hygiene, waste management, energy, management and workforce, and environmental cleaning within selected facilities. Secondly, to determine the factors associated with practicing environmental cleaning and hygiene among healthcare workers in selected facilities. And thirdly, to integrate sanitation and hygiene decision-making tools into existing policies and strategies. This slide summarizes the methods that we used for those 3 objectives. For objective 1, we did interviews and observations in healthcare facilities using the Wash Fit tool. In Senegal, this was conducted through a collaborative process where our partner in Senegal, PES, worked with private sector and government departments to engage and jointly deploy the Wash Fit tool in 3 healthcare facilities, 1 hospital and 2 lower health facilities. In Uganda, we used a similar approach and we deployed the tool in 8 healthcare facilities, 3 hospitals, and 5 Health Center 4 and Health Center 3 facilities. When it comes to objective 2, we undertook a cross-sectional survey among 369 healthcare workers in the Greater Kampala Metropolitan area. This was done in public healthcare facilities at the levels of hospital, level 4 and level 3. And lastly, in terms of the integration of the tools, we used stakeholder engagements and consultations, and we worked with different experts to integrate the sanitation and hygiene decision-making tools into existing policies and guidelines. Now, when it comes to the results from the formative phase, this slide highlights the results from Senegal. As we can see, on the extreme left are the Wash Fit results from the large hospital in Dakar, and what we see from that figure is that the performance of the large hospital across the different domains of the Wash Fit for this hospital was generally good when compared to the lower healthcare facilities. However, the performance of management and workforce and waste management was slightly lower compared to the rest of the domains. When it comes to the lower healthcare facilities, performance across the key domains of the Wash Fit was generally poor, with these 2 facilities having mainly limited and none in terms of the JMP performance levels. In Uganda, the results were quite similar to the picture that we saw in Senegal. For one of the hospitals where the Wash Fit tool was deployed, this is Lubaga Hospital, we see that performance for the key wash fit domains, that's water, sanitation, waste management, environmental cleaning, and hygiene. Across those domains, this hospital scored the basic JMP level, and performance was generally good. When it comes to the lower healthcare facilities, we see that lower healthcare facilities like Kasanga had performance for key wash domains generally good. However, it was only water supply that had the basic level, and the rest of the facilities had limited and none. And the picture that we saw in the other lower healthcare facility, which is in Aweru, is quite similar to what we saw in Kasangati, with only the basic JMP level appearing only for water supply. Generally, we recognize that there was a distinct, there was a difference between the performance of the larger hospitals and the lower healthcare facilities, and this could be attributed to differences in funding. Larger hospitals tend to get more funding in terms of the primary healthcare funds, but besides that, there's also a difference in terms of the staffing levels for the larger hospitals and the lower healthcare facilities. When it comes to the factors associated with environmental cleaning practice among healthcare workers in Uganda, we had two factors that were significantly associated with this practice, and that included receiving training on infection prevention and control, as well as having support from health facility leadership. Lastly, in terms of stakeholder engagement and integration of tools into existing policies and guidelines in Uganda, we had the sanitation and hygiene decision-making tools integrated into the sanitation and hygiene policy, and we also had the tools integrated into the Ministry of Health Environmental Health Strategy for 2025-2030. In Senegal, a lot of efforts have been undertaken. The Ministry of Health is working on integrating the tools into the health policy. They have a national stakeholders working group, and they've digitalized these tools to help healthcare facilities monitor aspects of WASH and IPC in the health facilities. Thank you.
Thank you so much, Richard. So now I'm pleased to introduce to you Dr. Swaib Semiyaga, who is also from the Makerere University, but representing the engineering perspective. And Dr. Swaib, please come up. I'm just trying to get your, there we go. Okay.
Okay, thank you so much. I'm here to present to you the insights from the ongoing work in Uganda and Zambia about the community pathogen hazard associated with sanitation systems. In brief, we call it the Compass tool. The Compass tool, we all know that adequate sanitation can reduce exposure to fecal pathogens and also excreta-related diseases in communities. And also, we know from where we are coming from that in our towns, most of us are having sanitation facilities, on-site sanitation facilities, but we have less knowledge on the potential reduction of pathogens that they have. And also the sanitation investments done in these towns, most of them are not linked to the ability of these sanitation systems in reducing the healthy the health issues. And the campus tool here comes in to bridge that gap, to make sure that when investments are being done, we are prioritizing areas that are reducing the exposure of pathogens to communities. So in this work, briefly, I'm going to talk about the different typologies of sanitation systems that are used in Zambia and Uganda, and also looking at how these designs of the sanitation systems and their operation are related to reduction in pathogens, and also this will be integrated. So this data will be integrated in the campus tool, which is under development. So now this work was started by having community transact works both in Uganda and Zambia to observe the different sanitation facilities that are used in communities, and also observe the different designs, the different operations and maintenance. And also we're able to look at the, we're also able to do the key informant interviews and sanitation technology user surveys. And these also were done to also know what the users know about their facilities, what kind of facilities that they are having, the design of facilities that they are having, and their operation and maintenance. Also, after that, we are able to look at environmental sampling, sampling from the sanitation facilities, from the sewers, from drains, from the compounds, and also we wanted to know how these different areas are contaminated with pathogens. In brief, I want to let you know about some of the insights from the results that we are having. I'll just say that we are seeing that in both areas, that is Zambia and Uganda, the sanitation facilities used do not meet the design standards. They don't meet the design standards. I'll say if you look at the fully lined tanks, I'll say in quotes, which we, some of you call the septic tanks. We call them fully lined tanks because most of them did not meet requirements of septic tanks. So the designs were not well met in a number that has been sampled so far. And also when it comes to the lined pit latrines, where we have the lining of the pits either side, all partially or full lining of the pits. So another result to talk about is about the load, about the E. coli load with the different sanitation facilities. If you look at the fully lined tanks, which I talked about in quotes, which people call septic tanks, and lined pits and unlined pits, in both countries, you see that the indicator pathogen load is lowest when it comes to fully lined tanks. And this you can see in Uganda. I think if you look at the variation in Uganda, is due to having quite a number of different typologies in fully lined tanks than in Zambia. And when it comes to unlined pit latrines, you can see Zambia does not have so many of unlined pit latrines, but Uganda has quite a lot. And you can see when it comes to the indicator pathogen load, it is higher in pit latrines, the lined and unlined pit latrines. If you look at the operational practices, so not only limited to the typologies, but also the operation, you'll see that the first graph you have on the, I don't know whether that is the right or left. But on your left, so if you look at that graph which you have, you'll be able to see it's about storage, mainly looking at all the containments that we have sampled so far in both countries. You realize that we have the indicator pathogen reduction when it comes to storage, with more storage. And this was significant mainly after 1 year. So you can see how also storage contributes to reduction of pathogens when it comes to sanitation facilities. And this also has implications to the design and operation of sanitation facilities. When it comes to another result on your right or my left, now this one you can see if you look at the users to volume ratio against the pathogen indicator, you'll see that the more the people, the more the people using facilities, the more the pathogen indicator load, and this also has implication on the number of people using a facility. So if you look at an example of informal settlements where you have quite a number of people, and also the implication on the emptying frequency when we are emptying much more, because also the more the people having access to a facility, also the more the emptying cycle, and also the increase in the pathogen indicator. So you can see quite a lot of implications, but in brief, you've seen that we have issues, first of all, with the designs of the sanitation facilities in these countries, I guess even in more other countries, but here the insights are from Uganda and Zambia. And also the poor designs which you have seen, you have also seen that we have issues when it comes to the technologies with pathogen indicator. So yeah, it will be important to look at sanitation standards, those countries that are not having sanitation standards, and also enforcing the standards. If you look at the fully lined tanks, so you could see that if again the fully lined tanks were made to be a standard, like having standard septic tanks, you can see that also the standard septic tanks, like the ones which the fully lined tanks which you had, they didn't have buffers and so on. Now, if the designs are emphasized and say you have the buffers, you are going to increase also the removal of the pathogens before it joins the environment. So another issue here is on the risk-based sanitation planning, which is mainly the purpose of this tool, the Compass tool. Because if you look at a simple example where you have the unlined pit latrines, and these unlined pit latrines that have a higher pathogen indicator load, and then they are, so for example, present in informal settlements or places where people are so many. So if you look at the sanitation investment with this tool, you'll see that it will be targeting such kind of areas, but all this is to be done with this tool. So I want to let you know that the tool is under development, integrating these results and also collecting more data. Thank you so much.
Okay, Thank you so much, Dr. Swaib. And now we have Dr. Nuhu Amin from icddr in Bangladesh.
Thank you, Christine. You can find that presenters are a little bit in pressure because country presentation in 5 minutes. So I'm also going to present 2 countries' data. One is with the experience of field staff, how they actually collect the data, what sufferings they have, and a little bit overview with this.
Under the PROMISE Consortium, the Sanipath project aims to identify and quantify key fecal exposure pathways in urban areas of Bangladesh. Our field team, led by dedicated staffs like Raju and Debashish, is working to generate evidence that supports safer sanitation, hygiene planning, improving water quality, and hygiene for healthier communities. The study focuses on Weiga Municipality in Khulna, Bangladesh. Using the Sanipath tool, we assess how people are exposed to fecal contamination through water, food, and environment. The team collects behavioral and environmental data from households, markets, and schools. Over 236 environmental samples and 246 behavioral surveys were collected, including flood water, surface water, drain water, drinking water, raw produce, and street food samples. Each sample is carefully handled, sterilized, and stored on ice before being transported nearly 300 kilometers to Dhaka for laboratory analysis. Raju and the field team faced multiple challenges, including long travel distances, lack of local accommodation, and no nearby laboratory. Also, heavy rain, political unrest, and poor road conditions made sample collection difficult. But the team adapted through careful planning, community support, and teamwork. Despite the odds, the team successfully completed data collection through collaboration with municipal officials, local leaders, and WaterAid. Furthermore, every challenge became a lesson by strengthening our understanding of on-ground realities in sanitation research. This journey reflects the dedication of field staff like Raju, turning evidence into action for safer and healthier cities.
Okay, as I mentioned earlier that I'm going to present the Ghana and Bangladesh teams data, and already Christine mentioned about the cholera challenges about on the LMICs, especially Ghana and Bangladesh. 2 different scenario, but the disease are also same. So you can see that in recent data and recent outbreaks from cholera is also mainly caused by poor food hygiene and also weak sanitation infrastructures. And also these outbreaks are very high with morbidity and mortality with lots of children and adults as well. In Bangladesh, the scenario is different. We know the causes, some causes of cholera and diarrhea causing pathogens, but government don't have the specific data that where should be actually invested. So WaterAid actually investing in Weiga Municipality, which is one of the opportunity for the Sanipath team Bangladesh to assess what should the investment or wash intervention needs to be assessed. So this is actually considering one of the built-in environment where we can actually get the data, and then we actually request the WaterAid to invest appropriately to improve the wash in this municipality. So in Ghana, key issues actually identified through the key informant interviews or stakeholder engagement, like fragmented policies on water, sanitation, and hygiene, and then weak enforcement and the food hygiene and produce handling of the vendors, untapped revenue potential. So it's not very much easier to actually collect the revenue from the wash infrastructure and wash service from the municipalities, and shortage of trained expertise, both from government and non-government people on wash infrastructure and wash behavior, and improving how to actually improve the wash. And finally, the rapid growth of food vendoring in Ghana is one of the biggest concerns, with poor or no policy at all on this thing. In Bangladesh, alternatively, pipe water is one of the very popular in municipalities, but the regulations for pipe water is not that much, and how it is contaminated is also not very much clear most of the time. In this municipality in Paikgache is one of the most climate vulnerable areas, where water, food, and other unhygienic practices very common in this area. And capacity building is one of the another challenge in Bangladesh, particularly improving the water and sanitation, and that's another things this project is also actually wanted to improve. And these are the collaboration we built with WaterAid Bangladesh, and they are going to invest in water treatment and hygiene, but we are actually, this data will provide how can we actually this intervention be more effective. At the same time, Ghana team is actually doing the stakeholder engagement to improve their intervention and how their data can be actually utilized. The overall objective is to identify and quantify the key fecal exposure pathways and urban environment in Bangladesh and Ghana using the Sanibat tool, generate reliable context-specific data, behavioral and environmental exposure for fecal contamination, and guide policy and investment. And specific objective for the Ghana is to provide evidence to update food hygiene policies and make practice. And for Bangladesh, provide evidence to guide the WaterAid for the implementation of the wash services. And the study site in 4 wards in one municipality, which is Paikgache municipality, which are in the very highly vulnerable coastal area. And another is Ghana. They are working on 4 municipalities with different geographical variants. Bangladesh is planned to, Bangladesh already collected information about drinking water, flood water, surface water, drain, and street food and raw produce. And Ghana collected information on raw produce, street food, and drinking water. Very briefly about the street food and raw produce, like Ghana result, you can see that among these people's plot, so more the darker the color, the more contamination with the fecal indicators. And more the number people actually with the dark color, more people actually exposed with that type of exposure. For example, in the right side graph, the upper panel is for the adults and lower panel is for the children. And you can see the first one is produce, second one is street food, third one is the drinking water. So produce and street water is consistently very much highly contaminated and highly exposed by both adult and children in Ghana. And our behavioral survey also found that in Ghana, awareness about the food hygiene is, hand hygiene is also very high, but their practice is actually not that much. So that's one of the biggest challenge in Ghana. For Bangladesh, you can see the exposure is totally different than Ghana. So in both adults and children, the drain water, flood water, and drinking water, those are exposed by both adults and children, but street food is predominantly by children. And the concentration of pathogen, like E. coli contamination, is almost very high for all the exposure, and you can see that flood water, surface water, drain water, those are 100% positive and with high concentration with E. coli. And water, drinking water, and other water is also like highly contaminated. You can see drinking water is about like 80% in one ward, and 62% in another ward is contaminated with fecal indicator bacteria, which is directly consumed. At the same time, the street food is also contaminated with different type of pathogens, particularly E. coli is highly contaminated with this. So these different type of information provide us that where should actually wash intervention, whether you need improvement of the drain or whether you need improvement of the water in different geographical variations. So these data will provide to the WaterAid Bangladesh so that they can actually make decision and change their intervention. So very briefly, the Ghana actually improving, trying to actually key findings to improve awareness, like viable and invisible, visible versus invisible hygiene products, institutional awareness. So they had lack of institutional awareness they have found, and culturally they have some very difficulties they have found about that keeping the staff, trained staff most of the time, and also like behavior is also very much key factors that they want to improve. At the same time, they have the future practice, that what should be the future direction. So food safety, regulatory reform, institutional strengthening and capacity building. So these are their future directions they want to actually employ. For Bangladesh, it's also been same, but mostly our plan is to integrate this with the WaterAid interventions, and also like there are a couple of tools, sheet flow diagram, C-wise, and like sanitation safety plan. We would like to implement this with this data, with the things. So thank you very much. Hopefully, next we will discuss about more on this Sanipath tool. Thank you.
Okay, a big thanks to all the speakers because they're presenting more than a year's worth of work in multiple countries in 10 minutes. So please give all of our speakers another. Great. So now we're going to move on to the panel discussion, and that's going to be moderated by my colleague, partner in crime, Dr. Musamanga.
Thank you, Christine. We're just going to go to the most exciting part for the side event. And I'm going to invite the panelists. But the main thing about this is to actually engage with the audience. And we're going to spend more time hearing from you, raising all these key questions, important questions on how group science can actually be improved moving forward. One thing I'm going to start with, we have some of our partners, they wanted to be here, and they're not going to be able to be. And they were supposed to be on the panel. They tried, because of the visa issues, they couldn't make it. But they felt it's really important to share their insights. So they have recorded some videos, which we are going to play. Each video is about 2 minutes, because we told them, we want you to be very brief, because we want to hear from the audience. So one of the partner we have is actually coming from Kenya. And basically, she's talking about the importance of stakeholder engagement. If we can make this possible without involving, having this kind of stakeholder engagement. And she's trying to talk more about that. So I'll play the video.
Thank you. Allow me to begin by saying that stakeholder engagement is an ongoing process that should begin as early in the research process as possible. Stakeholders are also varied, ranging from the community level to the national and international level decision makers and influencers. In the PROMISE Consortium, we have tried to engage as many of these stakeholders as possible. And in terms of lessons learned, I'm going to highlight 3. The first is that stakeholders have first-hand knowledge, and their engagement always leads to a fruitful process of cross-learning. In the consortium, for example, we are from diverse disciplines and we are implementing a number of tools in our countries. So as we come together, each of our different disciplines, knowledge, and from each of the countries, we are able to learn from each other and to come to a shared understanding of how the different tools can be used to influence decision-making in each of our countries. The second point is that stakeholder engagement often leads to identification of local challenges and also local solutions. In Kenya, for example, we are implementing the Compass tool, and we have had engagement meetings at the community level, at the national level, and at the sub-national level. At the community level, for example, the community members were able to map out their sanitation facilities and to identify challenges. And even in that process of engagement, were able to also identify solutions to some of the challenges that they identified. The third and final point is that stakeholder engagement can lead to identification of local challenges that can then define donor priorities. Oftentimes, you might find that donor priorities might be different from the local priorities. Now, through stakeholder engagement, communities are able to define their local challenges, and these challenges can then define donor priorities. Now, when stakeholders are then involved in implementation of solutions to the challenges that they identified, then they are even more motivated to be part and parcel of the solution. Thank you. Those are the 3 points that I can talk about today, and back to you. Thank you.
Thank you so much, Sheila. She kept 2 minutes, kept it very brief. She was trying to save time because she was supposed to introduce herself. So she's called Sheila Simiyu from APHRC in Kenya. The other partner we are having is actually coming in from Zambia, and he's going to be talking about how he has used the complex sanitation data to inform actionable or recommendation or policy. And that's going to be Edgar from Zambia, Lusaka.
In cholera cases, year in, year out, attributed to the challenges of sanitation, especially in very urban areas where we have more cases. Interventions have been done, but we see these cases not ending year in, year out. The interventions which have been done mostly are done without effective risk assessments. However, for us to ensure that we effectively deal with the challenges of cholera cases, we need to ensure that we have effective sanitation data which should help come up with interventions which are evidence-based. In the recent past, we've seen some improvements where data on sanitation has been generated, and this data is helping the policymakers from the highest, that is national level, at provincial level, even at district level, that is the local authorities, making decisions using the sanitation data which is being generated. I'm happy to say that the Promise Consortium, which has come in, is also helping to generate this data. In the recent past, we've seen the generation data we've seen the SunPath 2, we've seen the WashFit 2, and also now the Compass 2, which are being used to generate this data. And the different partners within the consortium are working together to ensure that this data is generated so that policymakers can be helped to ensure that the interventions being put in place are interventions which are evidence-based. And we are happy to collaborate with different partners across the globe who are part of the Promise Consortium, because without collaborations, it's very difficult to have even the needed skills, even experiences, because different countries have got different experiences which are helping to bring about the knowledge on the part of other countries where knowledge might not be that much. Thank you.
Thank you so much, Edgar. We're supposed to use the 30 minutes to engage with the audience, but that's what we're going to do. But before we go there, we want to fly to Ghana and use 2 minutes. We want to hear Ghana talk to us about tools. Tools, everyone is developing tools, but the issue is, how do we work with governments to institutionalize these tools? So we're going to hear Ghana talk to us about how they have used the SandPath tool, the Compass tool, the WashFit tool, and work with governments to institutionalize them. So I'm going to have Otto from Ghana to talk about that.
The promise work in Ghana has been focused on food safety and hygiene. I would like to talk about how evidence from this work and the result from the SaniPath deployment have supported decision making, or how the evidence has been embedded in taking decisions around new changes within the sector. One of the major entry points for embedding or integrating evidence-based decision making in national planning and actions is stakeholder engagement and involvement. So right from the onset, we organized a national stakeholder workshop that brought together different partners and actors within the space, which helped us to zero in on what are the key priorities, what are the key policy gaps and issues for the sector when it comes to food safety and hygiene. Through that, some of the outcomes led to joint action planning, co-creation of the foundational research that gave us the evidence and results about the food safety and hygiene situation in Ghana, and also aligning with co-creation of interventions on how to respond to that. Through this, we also jointly work with the Ministry of Local Government and the municipalities to co-design and implement the research that led to the outcomes that is informing actions now. Some of the key actions that has come out from this work is through the result of the research, we've been able to now start the process where we are updating the standard operating procedures for environmental health practitioners in the municipalities on food safety and hygiene. This SOP was first issued in 2002, and after 17 years, through this research, we are updating this particular guideline. Some of the other actions that has emanated from this work is an attention to improve the monitoring and engagement, and to some extent try to innovate around some digital approaches to how environmental health officers conduct inspections and also provide certifications and permitting for food safety food vendors in the country.
Thank you so much, Otto.
Thank you.
We've used all the time we had to use for that. We want to use 30 minutes to engage with the audience. We wanted to start with people who had to fly in from that far to actually share with you their insights. But now I want to invite some of the 3 panelists we have here in person. We luckily managed to make it here. We have Dr. Richard Chimwaga from Tanzania to come forward. And also we'll have Dr. Tanveo Hamid from Bangladesh also to take your place. And lastly, we'll have Dr. Syed Usman to actually take our place. Most of these people have got different years of experience working in the sector. As much as they hold PhDs, they are not like professors throughout, but they're spending more time with experience. Some of them have spent 30 years, others have spent 20 years working in the sector. And what we want to engage on are all things which are actually related to the Promise Consortium. One of the main reasons we want to engage with them is we know that one of the most powerful aspects of the Promise Consortium is how it's committed to group science, how we bring people from the global north and south to work together to co-produce evidence which can actually be used to inform decision-making for sanitation and hygiene. And along those lines, I want to start with Richard Chimwaga. I want you to use 1 minute because we need to mostly engage with the audience. So we want you to give that opening. What I want you to talk to us about is tell us exactly and be honest how the Promise Consortium's north to south and south to south collaboration has modeled evidence, okay, generated that evidence that's helped to improve local research capacity, and tell us how they have worked together to generate that high quality evidence. Thank you.
Thank you very much, Musa. Good afternoon, everybody in the room. A minute to be honest, Musa. Yeah, surely I have to be very honest that one of the most critical aspects with the Promise Consortium with regard to the objectives was to have the capacity in terms of carrying out the research. So by having the collaboration between North, South, South collaboration, actually we have experienced great increase in terms of research capacity at the local level. Starting with the North-South collaboration, I think you'll know that with evidence-based kind of decision-making tools, it's very important to have a thorough understanding of the tools themselves. That is something that has been actually undertaken within the consortium. That's number one. But also the other most important thing is the fact that not only having the tools, but also the credibility of data is something which is equally very important when one is just going into the evidence-based kind of decision-making tool. So in that particular aspect, actually within the consortium, a lot of capacity building have been undertaken, and one of them is in terms of enhancing lab analytical capacities in just determining the E. coli, because I think, for instance, if we give an example of the Tanzania, where the lab we are just implementing used to do the analysis in terms of fecal coliform, but now with the deployment of these tools, that means Sanipath as well as Compass, we have to do the analysis in terms of E. coli. But in the beginning, our lab didn't have the analytical capacity, but even in terms of protocols, these are the things that were not there. But with the consortium, actually, we have been building the capacity, and that has helped quite a lot in terms of improving and getting the credible data, which we think is very, very important for evidence-based kind of stuff. That's one particular aspect. But the last one, a minute, Musa, is on the fact that in addition to having the activities within the consortium itself, but also we are experiencing what we call the spillover effect, because I think the consortium has built the capacity in terms of writing research proposals. That is something that we are actually enjoying within the consortium. But I think that's the honesty that I have.
Thank you so much, Richard. I think based on what you've just said, everyone would love to be part of a consortium. And the question is, and this is what I'm actually going to put forward to Dr. Uthman. We would love you to share with us what mechanisms have proven to be more effective in ensuring equitable leadership, authorship, recognition in this consortium, so that other people can learn from us to start their consortiums, or even pushing forward or joining more of these. Could you tell us more on that, please?
Yeah. Thank you, Musa. Thank you so much, and good evening, everyone. It's my pleasure to be here. Musa, I can't start without thanking the WaterAid Foundation. The Gate Foundation will enable us actually to carry over this work and building over 10 years of experience working in the sanitation sector in Senegal. I would like also to thank the sanitation director of Senegal, who is present in the room, who actually at the very beginning helped us and then accept to be a steering member in the committee of the consortium. One of the things that I really can share in building consortium, there are three things: the value proposition for your consortium, equity, and leadership. Within leadership, within our consortium, at the very beginning, I think the wealth of expertise attracts each one of us to be able actually to quickly see that we can complete each other's. And the second thing is the way we build our governance structures, which is transparent, but also flexible to solve issues within communications among ourselves. Gender mainstreaming is something that really I cherish in this consortium, because I see how the leadership is being really handled within us to enable us. I think we never had a conflict or issues within ourselves because of transparent communications and having Christine on driving the wheel. We're very grateful to that. The communication mechanism that we have put in place, where actually each team get the fair space to exchange and then make sure that other members understand country context, is very important. And this is when actually we really conduct research methodology, design and thinking. All the members of the consortium are interested in hearing from others' experience. How do we implement the same tool? Like we do in Uganda, we do in Senegal, but we don't have the same context, but we learn from each other. That will allow us actually to even understand the differences that we have from our results. The other one is strong coordination mechanism that actually the team is putting in place, supported by the University of North Carolina, Emory. Team, thank you so much. This is a very strong coordination mechanism that is closely built within our consortium, and we become really friends in working together. These are the things that I actually share, Musa, that I can to share with the public. Thank you so much.
Thank you so much, Uthman. I think I'm glad to hear that. Because I want to open this to the audience, I just wanted to ask one question, and that would go to one of our collaborators. And the question that comes to you, all people have just presented here, they're talking about skills, data, they have got institutional networking. This is a project that has been given a time frame. How can this be sustained beyond the project timelines? And how can this be mainstreamed into watch programs and so on? How could you tell us, how can you advise on how we can do that from what sustainability of the consortium?
Thank you, Musa. Also, it's very nice to be here, and thanks for the question. It's a very relevant question, and we are all looking for answers, particularly for this. And it's not for this project, but also other projects where we have a big a research component and a lot of evidence generation is happening. How do we sustain those activities beyond the timescale of the project? Now, here we definitely have acquired some skills. Some learnings have been here. We developed data systems, and a lot of institutional collaboration has been made, definitely. But it's all what we see typically after the lifetime of the project. Some of these activities not carried out or are not really ingrained into the national system. So we have to look forward to it. We need to understand how these learnings can be really ingrained into the national WASH programming, and that will kind of facilitate some sort of demand-driven approach, so that there will automatically be a demand to learn some of these things. One example I always try to give is the example of the grand upscaling of the sheet flow or waste flow diagrams that the fecal sludge management community commonly uses. It was that kind of something which was needed a lot of learning, but when we really tried to push it into the national systems, for example in Bangladesh, we regularly and routinely use this for designing our development projects and sanitation interventions, and it is routinely being used. Since it's routinely being used, these have all automatically found its way into the training program modules, into the national curriculum, and also there is always the government officials and those who are working in the local government institutions. There's automatically an urge to learn how do we develop these things, how do we learn about these things and apply these things. So it will be important. For example, all these tools, or at least some of it, so we try to use it in our national WASH programming scenario. Let's say future sanitation projects, we'll have to find a way how we can use, let's say, Sanipath, Compass, WASH Fit, how these can be ingrained into the national development planning proposals. If that is in there, then we don't need to look about upscaling, because then there will automatically be a demand to create this, to have these upscaled. And then you will find that these will go into the curriculum, they will go into the training programs, and will automatically be a demand for capacity building. And that's, I think, one way to upscale some of these and have it ingrained in the system. Thank you.
Thank you so much, Prof. Tonville. Right now, we're going to get to the audience for questions. I know there are quite a lot of questions out there. People online, please feel free to put your questions on chat. Someone will be able to, read them out here and respond to them. Sure. We have the first question there. I think we can have the microphone.
Thank you so much to all the presenters and panelists. Really informative. So I have 3 questions for Dr. Swan. These are mainly regarding the policy implications of the research that you presented. So the first one is actually regarding the household surveys that you did, the user surveys. So we know that one of the main challenges for household sanitation surveys is that a lot of the households in low-income areas are tenants, and they don't necessarily know what sanitation systems they have. So I know that you also did the technical observations. So what percentage of the responses of the household surveys were actually confirmed by the technical responses, and what do you think that means for local governments like KCCA, for example, that has been trying to sensitize households and get households to upgrade their pit latrines from unlined to lined, for example. Then the second question is regarding the part about storage time that you presented. So we saw on the box plots that the median actually decreased. The median pathogen load actually decreased as the storage time became longer. But then I also noticed that the interquartile range actually expanded, and also the maximum fecal load, the pathogen load, is actually the largest for the 5 years and beyond. So I'm just wondering what could explain this kind of wide range, and what kinds of, is this associated, for example, with different household practices? So just wondering why that is the case, because I think it would have implications for what practices we're going to recommend to households, right? And then the third question is regarding the different sanitation systems. You presented that the fully lined tanks would have the lowest pathogen loads, and then also if we take the median value of the storage time, then we also know that as your storage time increases, then the pathogen load also decreases, and then there's also the emptying practices. So among all of these different practices, given that household and local government resources are very scarce, so what, in your opinion, would be the most cost-effective intervention in terms of pathogen reduction? Thank you. I know it's a lot. Thank you so much.
Those are all great questions, and I think Dr. Stripe can take some on, and I'm happy to support.
Okay. Thank you so much. Now, for household surveys, as you've said, we have tenants, most of them who may not know about their facilities. Now, the tool that we had was not only limited to tenants telling us that I'm having this kind of a facility or something like that, but the technical observation was able to identify all these kind of details of the facilities that they're having, the designs, and so much about the detail was being done by the team that understand these kind of facilities. So this was not a big problem here. And also about the fraction, which are saying maybe fraction of what they are saying that may not be the right one. They think this is the right one, but in actual sense may not be the right one. That was already rectified by the technical team doing the observation, doing what should be the right thing, not leaving this to them. But they are contributing quite great insights on the practices, because this is what they really understand. When did they last empty? What do they do with this? How do they clean it, and so on and so forth. Then also in brief about the storage time. The storage time, yes, there is the median reduces with time, but then you have the interquartile range on some increasing. I think also this was a combination of different technologies. So you find that all the technologies, when they are put together to see how the behavior is with time, I think this could be attributed by those different kind of technologies that were being considered. But later on, again, as we said, in the next step, we are going to look into much more deeper understanding on what is contributing to the die-off of these different kind of the pathogen indicators. But also, the colleagues you're working with could be able to explain more on this. The last one, I think I did not get it well, but.
Okay, in the interest of time, I would let you know we'll have another detailed presentation about this on Thursday, and that will go into the whole. We had only 10 minutes to present results from 2 countries, so you had to summarize all that.
Yeah.
Okay.
Actually, we have 2 more presentations in detail.
Yes.
Yeah, good afternoon. I just have a question in reference to your collaboration with the policymakers and governmental agencies during the research process, especially in Ghana.
Great question. Thank you so much. I'll ask Habib to respond to that. And he's going to give the closing remark.
Thank you so much. So I'm going to talk on behalf of our team, the team in Ghana. So I think the approach has been, and that's what the whole group is replicating, is to be really bottom up. So all the research you see doctors presenting them, but it was driven by local interest and what's important for the government. So for example, in Ghana, the work that has been done has been focused on drinking water, street food, and raw produce, mainly because there was a cholera outbreak, and it's still ongoing from Ghana last year, and it spilled over into this year, but it was linked to raw produce. So the government wanted to understand, they don't want this to be an annual thing. They want to understand how can we, what kind of tools can we use to really prevent this in the future. So what has been going on now is that the government has policies and manuals for environmental health officers in the field to use, but it hasn't been updated since I think 1997. But because of this work, the team in Ghana is working collaboratively with the ministry to update these protocols based on this evidence to support them in terms of, that's the part of the institutionalization, to support them to use these tools to be able to prevent these types of outbreaks and keep hygiene, a safe, hygienic environment. Thank you.
Thank you so much, Habib. Questions? Yes.
Mine is not a question, but curiosity, how some of this work can also drive the industry. In the end, of course, government sets rules, policies, and regulations, but you have industry that drives these products and services to the actual communities. So thinking about how really research and this evidence can be integrated into industrial practices that that actually drive businesses. You remember the plenary session today, but also investments that create lasting impact in the communities we want to serve. It's a curiosity comment, but probably someone wants to add an observation around that. Thank you.
Thank you. That's a great comment. I'll give Uthman 1 minute because I have another question coming in from Jane. Just in a minute.
Thank you, Musa. I thank you, Dr. Najib, for that question. I think it's very important. In the area where resources are very scarce, this evidence actually from us, we started from the Municipal Development Plan, which is actually where we map out needs and skills for capacity buildings. And then we move up now to the Ministry of Water and Sanitation, where actually we get support from what is mostly needed when it comes to actually developing tools and instruments to enable household and industry to look at actually how do we respond to community needs in terms of sanitation structure and solutions. We were able actually from this evidence to mobilize industry around this neighborhood to actually finance some of the lacking toilets and water resources within the same community using what they call the RSC, which is the Responsibility Social Investment that industry in this community can actually really share with the community to help them overcome certain social challenges. And I think in doing so, we open up the ways where community can actually engage with the local entrepreneurs and then understand that actually working within the community can be beneficial in terms of really helping them address certain solutions. Another thing that we actually were able to do from this result is now we are moving to build a really ecological treatment plant in one of the regions, peri-urban in Dakar, where actually community accept to pay on a monthly basis the sanitation services, which was not the case before, because now we are bringing public health issues, hygiene and sanitation together, which actually would allow also the governments to bring the policy leaders to talk to each other, because Minister of Health, Minister of Waters, Environment and Energy did not talk to each other in the term of policy leaders. And then we are bringing now the university to propose solutions that can be scaled at the industrial levels, especially when it comes to medical waste treatment. That has never been the case for Senegal. None of these hospitals has actually a solution for medical waste, and the university has proposed a low-scale solution for that because of this evidence. Thank you for that question.
Thank you.
Thank you so much. I think we have 3 minutes to get a question from Jane, and Habib will be able to give the closing remarks. So, Dr. Habib.
Thank you very much. Sheila raised a comment, made a comment on stakeholder engagement. It's very, very important, especially when it comes to communities. I just want to know what level of stakeholder engagement. I hope it's not the tokenism kind of stakeholder engagement where we just say, okay, let's just give you an opportunity to say something. I want to hear the end of it. Where does it really stop? I know where it starts, but I want to know where it ends. Then secondly, I think it was raised by the gentleman from Ghana. This is great work, and it should find its place in the right places. And the right places are in the corridors of power, where people make the decisions around money, the funding, allocations, appropriation, parliament, councillors. Those are the people that need to hear this, but not in the science language. You need to break it down a little bit, because even when people get into parliament, even if they are scientists, they forget that they are scientists. And then my last one is a request for this team. Since you also work in Uganda, the Uganda Water and Environment Week 2026 is in March, the week where we celebrate the World Water Day. I really request that you participate, a side event or whatever you want to call it, so that you share this. You won't have problems getting the participants. They will all be there. So utilize the week to share these findings. Thank you.
And the only issue with visas.
Thank you so much, Jane. In the interest of time, I want to hand over to Habib to respond to your question in a minute and also use 1 minute to give a closing remark. So, Habib, floor is yours.
Okay, thank you so much, Jane. So I'll try to, since Sheila is not here, I'll try to talk on behalf. But because we work as a consortium, everything they do, we know about it. So I can confidently tell you what they are doing because we exchange. We do South-to-South peer exchange, and we talk frequently. So even in the decision in terms of the tool that they want to use, it was bottom-up. They went to the community, they talked to key stakeholders. There were various tools that were available to them. And through stakeholder engagement, which is from bottom of the community to the national to the municipal level, they were able to say, this is our priority. So that's how they work. And this is the same model we are using across all the groups. So that's one. In terms of Ghana, yes, I hope the Ghana team is on also. They are listening to make sure that the people at the corridors of power hear about this. I think they are pushing very hard, but you know how difficult it is. And hopefully they'll be able to do this. And then for Uganda Water Week, I think there's a plan already, so we have that on our calendar, and I'm pretty sure that the team will be there to present in Uganda.
Closing remarks.
Okay, so closing. Thank you so much, everybody. And this work took a lot. You can see it, a lot of effort. I don't want to apologize for the people, the team that took the videos. They did multiple takes, so I don't know how they be feeling now. I think it's probably a technology issue. That's what happened. But I want to really thank them because it wasn't easy just getting them to record this. They send it, we comment, they send it back, they record, we send it back. So, and this has been through all the presentations you see here. We say we work as a group. Every team, we meet with almost every team every week. Every month. We talk to each other. It looks easy, but it's really tough. It's not easy. If you want to replicate this, it won't be easy. But what we've learned is the advantages are more than the disadvantages. Because of what somebody has done, another group takes a leapfrog. They will not repeat those mistakes, and they're able to integrate it into their findings. I want to thank everybody here, especially the people here. Our panelists, thank you so much. Your visa issues, the way you got here, we know all that. Professor Mo, Dr. Musa, our kind, RGHI, Dr. Najib also here. Without your support, I don't think that this will be easy to do. When we first started this, we thought, but it's been a very tough journey. And we welcome, what we are doing here is trying to encourage others to also come in and learn. So we welcome teams who are interested in this work to also come together, so we form a partnership. In the coming weeks and months, you'll be seeing us more online because we want to not just limit this to just our team. We'll open this up. We'll be engaging in webinars, capacity strengthening activities based on this work, so that our work in terms of sustainability that we talked about would cut across, not just within these countries, but across where the need is most. So thank you so much for coming.
Now you know why.
He's in Ghana Water. Ghana Water, we are recognized subsidiary. So I said, Ghana Water. Yeah.
Oh, good to see you too.
Once he sees my name, he will know it's
Just have the photo of me here.
Open this up.
The photo of me.
No, it's fine. I'm filming. That's fine.
Yeah, that might have been it. I didn't come up.
Yeah.
Energized, and I was like, this is the guy from Showbread.
Yeah, the Gdawe guy. Yeah,
I was like, we need to keep him inside our space to tell us.
I know. So like.